So today I'm going to discuss about the COPD in the consultation station. So it's a continuity of my previous presentations. As you know, the PACES is going to change end of this year. It's going to be called PACES 23, and it has got two consultation stations. So let's move on and talk a bit about the COPD. So as you know, the consultation station includes history and physical examination. You have to answer any concerns of the patients, and then there are 5 minutes for the examiner to ask questions. So in the history, I've mentioned the salient points in red, as you can see it, and these are the buzzwords which you should mention in your history, and try to take the complete history. And your history taking should not be more than 7 minutes or 8 minutes. So we got here a 70-year-old lady who presented with increasing shortness of breath over the last week. She reports having a runny nose and sore throat as an increased sputum production over the same period. I'll talk a bit more about the history. Here you see this lady is 70-year-old and increasing shortness of breath over the last week. So COPD actually generally affects the middle-aged and older people. If the patient is young and they present with COPD, it should be investigated for inherited conditions like alpha-1 antitrypsin deficiency. Patients with COPD generally they present with dyspnea, particularly worsening dyspnea on exertion. And we all know that the primary pathology in COPD is the problem with the airways. There is chronic inflammation and small airway fibrosis, which leads to airflow limitation. So once the patient say that got difficulty breathing, and the onset is quite important because it will help differentiate between different causes. We know that acute causes of dyspnea actually include like cardiac failure such as myocardial infarction, or pulmonary causes like pneumothorax or pulmonary embolism. It can be upper airway obstruction. On the other hand, chronic onset of dyspnea is actually because of the chronic inflammatory states such as COPD or asthma or restrictive lung disease. So this patient also says there's chronic productive cough for the last 4 years with yellow white sputum. So she's a current smoker with a smoking history of 50 pack years. Cigarette smoking is the most important risk factor for COPD, with significant COPD affecting around 25% of smokers. And 80% of the patients who have COPD, they have a history of smoking. However, there are other risk factors which can lead to COPD. It includes the passive smoke exposure, also exposure to the biomass fuels for cooking and heating. So the amount and duration of the smoking is associated with disease severity, and therefore it's very important to take a detailed smoking history in patient suspected of having COPD. Moving on to the history, she denies an history of hemoptysis, night sweats, or weight loss. These are very, very important negatives, as we know that COPD is not normally associated with hemoptysis. So if the patient say got hemoptysis and it indicates a more serious pathology, this can be because of the underlying lung malignancy that can erode pulmonary vessels or pulmonary embolism. Other causes of hemoptysis, we can think about tuberculosis or abscesses or certain forms of vasculitis, and even in coagulopathies. Similar to these night sweats, they are not associated with COPD normally. They are associated with other conditions like malignancy or infections such as TB, and maybe certain rheumatic and endocrine disorders. So These are the very, very important negatives which you must ask for the patient. Then um, must ask about the weight loss as well, because unintentional weight loss is another red flag symptom, and it is very important to ask for in the history. While in patients with long-lasting COPD, they can cause some weight loss. It is more commonly associated with malignancy or other inflammatory conditions. Okay. Now moving on to the history, she is normally able to walk around 200 meters before having to stop due to dyspnea, but this has reduced over the past week. So remember that exercise tolerance is an important measure to quantify the severity of dyspnea. So a number of patients with COPD, they may present with decreasing exercise tolerance as their only primary symptom rather than a productive cough. So must ask about the patient exercise capacity. She has no other past medical history, particularly no known history of asthma. So there is actually considerable overlap between patients with COPD and those with asthma. So historically, COPD was defined with distinct subtypes. Remember, we used to learn that about the chronic bronchitis and emphysema and asthma. However, there is no longer any official distinction in the definitions. Rather, patients, even with asthma, whose airflow obstruction does not completely improve with bronchodilators, they can also be considered as having COPD. So, I think this was the detailed discussion about the history. So, let's move on. After the history, we'll have to do the examination of the patient. So in this, obviously, you'll start with the general physical examination, and which is related to the respiratory system, and then we move on and do the respiratory system examination. So on general inspection, the patient appears dyspneic at rest with the use of accessory muscles of respiration, and she is breathing through pursed lips. So there are some very typical features in patient with COPD. And remember that patient with emphysema will usually purse their lips. What happens actually, this narrows the exit of the airways and increasing the airway lumen pressure and preventing the airway collapse. Therefore, it is easier for the patient to breathe out. She is saturating at 86% on the air with a respiratory rate of 26. Heartbeat is 85 and her blood pressure is 135/85. So remember, in the consultation station, you can ask for these readings. So once you turn the general physical examination, or in the middle of the examination also, you can ask, I like to know the saturation of the patient. I like to know how is the blood pressure. Pulse, obviously, you can check during your examination. So on examination of her hands, there is no evidence of clubbing, but you notice that her fingers are nicotine stained. Important negative to mention that there is no evidence of clubbing, and if you find an nicotine stain, just mention it. A bit about the finger clubbing. You know, finger clubbing is actually an enlargement of the nail bed and fingertips, and is thought to be secondary to secretion of some growth factors in some chronic lung conditions. It is not normally found in COPD, but it can be sign of other conditions like bronchogenic carcinoma, interstitial lung disease, tuberculosis, cystic fibrosis, bronchiectasis, and even in some congenital cyanotic heart disease, endocarditis, and in addition, the inflammatory bowel disease like Crohn's disease, ulcerative colitis, or cirrhosis of the liver. These are all additional causes of clubbing. So nicotine stained fingers, these are a sign of cigarette smoking. Therefore, this has been found to be associated with a number of conditions due to smoking, including COPD. One of the important thing to look for in any patient with in the respiratory station is hysterexis. So if it is positive or not, you must mention it. So in this case, there is no evidence of hysterexis when her hands are outstretched. Now, hysterexis actually is the involuntary flapping tremors of the hands elicited when the hand is outstretched and bent upwards at the wrist. So these are more sign of a CO2 retention. So one must look for these signs while doing the examination, and particularly if it is related to the respiratory system. On examination of our face, there is no evidence of Horner syndrome, pallor of the conjunctiva, or central cyanosis. Important negatives to mention. Pallor, is a sign of anemia, and anemia is relatively common in the elderly patients, and these also can present with dyspnea. Obviously, if the patient has anemia, it should be investigated for source of bleeding, in particularly with thinking about the occult GI bleed, which can occur secondary to malignancy. Usually, patients with COPD can actually develop polycythemia as a result of chronic hypoxemia. Important thing to look for in any respiratory conditions, look for the peripheral cyanosis as well as the central cyanosis. And it is due to increased concentration of deoxyhemoglobin in the blood, and it's a sign of a poor arterial blood oxygenation and can occur secondary to issues with oxygenation in the respiratory system. Further, going through the examination, you've done this. There's no pallor or central cyanosis. Must know the position of the trachea. So in this case, her trachea is midline and with a reduced cricoid notch distance. So tracheal position, it indicates upper mediastinal position, which is usually determined by the intrathoracic pressure. So conditions that change the intrathoracic pressure can either push the trachea away, such as if there is any mass or trapped air, or pull the trachea towards in case of lung collapse or fibrosis. While in case of COPD, it does not cause tracheal deviation, but certain complications such as secondary pneumothoraces, they can deviate the trachea. Another important thing to see is the cricoid notch distance. The distance between the cricoid cartilage and sternal notch, it can be used to gauge lung hyperinflation. So when examining the patient, you should normally be able to fit 2 to 3 fingers in the space with a reduction in distance, indicating if there's a reduction in distance, then it indicates the hyperinflated lung. So moving on to our examination. On examination of a chest, there is reduced chest expansion with intercostal drawing during inspiration. So as a result of a gas trapping, actually patients with COPD have a high functional residual capacity, and this is a sign of hyperinflation. And this reduces the ability for the chest to expand during deep inspiration, so results in decreased chest expansion when measured. And similarly, intercostal drawing during inspiration also can happen. On auscultation, this chest percussion reveals symmetrical hyperresonance. So hyperresonant sound on percussion over the lung indicates the increased presence of air or hollow structure. And this could be secondary to hyperinflation COPD or in pneumothorax. On the other hand, if you feel the duller notes during percussion, that usually indicates the presence of a fluid or a solid mass. On auscultation, there is widespread bilateral wheeze. So wheeze, we know that is a secondary sound is caused by narrowing or obstruction of the airway, and we can divide the wheeze into high-pitched polyphonic wheeze or low-pitched monophonic wheeze. A polyphonic wheeze usually indicates obstruction of many different size small airways, such as in asthma. in COPD or cardiac failure, a monophonic wheeze indicates obstruction of a single large airway, such as in trachea or bronchial obstruction, secondary to a tumor or foreign body. Heart sounds are dual without any added sound. So the COPD does not directly result in a change in heart sound. Chronic severe COPD can lead to pulmonary hypertension, and this will lead to parasternal right ventricular heave and a palpable P2 examination, as well as you may find a tricuspid regurgitation murmur, because as the right ventricle dilates, there could be some tricuspid regurgitation. So it's a good idea to, while you're doing the respiratory examination, just listen to the heart as well to rule out whether there's any murmur of TR. Let's move on to the investigation. So this patient has an ECG. So what investigations we like to do? First of all, obviously, we want to do some basic investigations, bedside investigation, which is called like an ECG. And ECG will normally will indicate some right axis deviation, maybe a dominant R wave in V1 and dominant S wave in V5 and V6. So ECG is actually an important investigation in any patient with dyspnea, because it can be used to it helps to rule out any urgent cardiac pathology. COPD itself, it does not cause any ECG changes, but patient can develop pulmonary hypertension and right ventricular hypertrophy secondary to increase afterload. Right ventricular hypertrophy can be identified and it will result in the what we have discussed before. These are the typical findings in the ECG which we must look for. So she has a plain chest X-ray which relieves a flattened diaphragm, bilateral hyperlucency, and prominence of hilar vessels. So these are the X-ray findings which you will be expecting in a COPD case. A flattened diaphragm is a sign of lung hyperinflation, and bilateral hyperlucency also occurs in COPD due to presence of gas trapping within the lung fields, and prominent hilar vessels, well, they can be seen in the chest X-ray with advanced COPD, leading to pulmonary hypertension and carpulmonary. There is no evidence of consolidation on the chest X-ray. Important negative that there is no consolidation. She has a set of blood tests including full blood examination which reveals a mildly raised hematocrit and white cell count. So mildly raised hematocrit, we have discussed before that this patient can have polycythemia, so that could be expected. Her urea and electrolyte reveals a raised bicarbonate level but are otherwise normal. And she has an arterial blood gases which shows a partial pressure of carbon dioxide 46 and partial pressure of oxygen of 67. Though this patient is hypercapnic, so because they will increase partial pressure of carbon dioxide and hypoxic, and the patient is actually close to developing type 2 respiratory failure, which is typically characterized by partial pressure of carbon dioxide being greater than 50 mm Hg and partial pressure of oxygen less than 60 mm Hg. Patients with type 2 respiratory failure also are usually acidotic because of increased carbon dioxide, because of the raised carbon dioxide. So just to give you the idea, and the whole exercise which I want to do is so that you should be more familiar. I want to give you some food for thoughts that no need to memorize, but you should know what investigations I like to do and what will be my expected finding on these investigations. So moving on to the investigation, we like to do the sputum microscoping culture, and in this case it comes with a mixed growth. It It's not routinely actually performed for patients with COPD, as does not always affect the management. However, some patients who have a history of a recurrent infection or previous unusual uh, um, resistant microbiology, sputum microscopy in culture can help direct antibiotic treatment choice. She has an alpha-1 antitrypsin level which is normal. So alpha-1 antitrypsin, it is an enzyme produced primarily by the liver and that inhibit proteases, including elastases. And this is released by neutrophils as part of the inflammatory process. Now, elastase actually breaks down elastin and it reduces elasticity of the lung and leads to emphysema. So, but alpha-1 antitrypsin deficiency should be suspected in all patients with COPD, but in particular those patients who are young or do not have a history of smoking. Her most recent spirometry result shows an FEV1 of 2.2 liter, which was 60% predicted, and FVC of 3. So her FEV1 FVC ratio is 60%. So obviously lung function test plays very important part in the diagnosis of COPD and asthma, any obstructive lung diseases. So FEV1 FVC ratio less than 70% without bronchodilator reversibility is considered diagnostic for COPD. Other obstructive conditions such as asthma also it can cause FEV1 FVC ratio less than 70%, but they are associated with significant bronchodilator response. Usually it is greater than 12% or 200 ml. Here the CT scan which shows centrilobular emphysema. A CT scan is not required for diagnosis COPD, but rather is used to identify a complication of COPD, like patient with pneumonia or pneumothorax, or for lung cancer screening. However, it is better at detecting emphysema than a chest X-ray. So that was all about some of the investigations which we like to do in a case of COPD. Now we come to the management. So remember that management, it is always better to divide our management to different sections: immediate, short-term, and long-term. So this patient likely has an acute exacerbation of underlying COPD, so like to commence a supplemental oxygen if the patient is hypoxic. Nebulized bronchodilators such as salbutamol and epratropium should be given, and patient should be commenced on systemic corticosteroids. Antibiotics that should be considered with this suspicion of a bacterial infection, and obviously non-invasive ventilation should be considered for patient with respiratory failure. So systemic corticosteroid therapy can be either prednisolone orally or hydrocortisone IV. If the patient is unable to take oral medication, we can give the IV. And duration of a course of corticosteroid can vary, but usually 5 days is adequate for most severe exacerbations. And these corticosteroids usually help reduce inflammatory response through a variety of mechanisms, and they usually help with the COPD exacerbations. Antibiotics, but they are not routinely indicated in exacerbation COPD unless patient have features suggestive of like bacterial infection. In most cases, oral antibiotics are adequate to treat most patients, even those in hospital, with amoxicillin or doxycycline being an appropriate choice. What about non-invasive ventilation? It is indicated for patients with type 2 respiratory failure, not improving with therapy. And it has been shown to reduce mortality and usually avoids the need for intubations. But these patients need to be closely monitored in a specialist ward or in intensive care. So this was all about the immediate management. Then what about the short term? So patients should be educated about their condition and prognosis. Discussion about smoking cessation should take place. The pharmacological management should be considered in a stepwise pattern. So patients are usually commenced on short-acting bronchodilators such as ipratropium or salbutamol as necessary. If the patient is more symptomatic, Long-acting muscarinic antagonists or long-acting beta antagonists can be started. Inhaled corticosteroids, they can be commenced if ongoing symptom, with usually a combination inhaler being used. And mucolytic agents also can be considered. So, inhaled corticosteroids, the examples include budesonide, beclomethasone, or fluticasone. While the effect of inhaled corticosteroid on mortality is unclear, they are greatly used to aim to reduce the exacerbation rates. And we have combination inhalers are available containing both LAMA, LABA, ICS, and LABA, or all three classes of medication. And they can make it easier for patient to escalate further therapy for COPD without needing to use a number of different puffers. So this is the short-term treatment. And what about the long-term? So patient should be managed by a multidisciplinary team, ideally coordinated by the GP, but including a respiratory physician, a physiotherapist, and dietitian. And they can be offered for pulmonary rehabilitation. Patient with COPD resulting in significant hypoxemia, they will benefit from continuous home oxygen supplementation, and patients should have their influenza and pneumococcal vaccination. So pulmonary rehabilitation is actually usually a 6 to 8 week program and is aimed at patients with chronic lung disease, including COPD. Patients get regular exercise training and are taught energy conservation techniques. And they also educated about their condition and provided with some psychological support. What about the long-term antibiotics? Well, this can be considered, especially if the patient has a frequent exacerbation. Remember that the rotating antibiotics, which was previously teach that we can give the patient rotating, it is no longer there. So one should give the antibiotics, and then antibiotics, they can be also given in an inhaled form like colistin. So it depends on the patient condition. Patient can also be considered for surgical intervention or lung transplantation. So remember that patient with significant emphysema with marked hyperinflation, they may benefit from lung volume reduction surgery to improve their mechanics, which are suited with ventilation, because it helps to reduce the inadequate lung emptying. But this discussion would ideally happen in a tertiary specialist center. So as their disease progresses, patients should discuss advanced care planning and be referred to the palliative care nurses. So patient wishes regarding end-of-life care, including thoughts on resuscitation and intubation, should be ideally conducted when the patient is stable in an outpatient setting. And the palliative care team in the end, they can provide strategies to help patient with symptoms controlled at all stages of the disease. So this was a brief discussion about the COPD. I hope you find this discussion helpful. And I have already mentioned in my previous presentations as well that this is just to give you some food for thoughts and to think about it. Obviously, whatever source you are reading, just go through that one as well. I try to cover as many points as possible. In PACES examination, it is totally different because it's not a not a knowledge examination actually. It's all depends on your techniques, your approach, and your confidence. So once you have all this one, it will be quite easy to pass. Thank you very much, and I'll see you